Good morning, everyone, and welcome to the Future of Healthcare, the Next Frontier. I'm Craig Bartholomew, the Executive Director of Illinois for United Healthcare's employer business. Together with Northwestern Memorial Healthcare and ZS Associates, United Healthcare sponsors and co-chairs the Executives Club Healthcare Forum. We are excited to welcome you to a discussion on the ramifications that COVID-19 will have on the healthcare industry in the years to come, and the role and the innovation and new technology is played in the fight against its spread. United Healthcare has had an active community response to COVID-19, from funding various clinical trials, providing grant money to the University of Chicago to expand COVID testing in Chicago, providing $1.5 billion in premium relief to our customers, and keeping our large campus cafeterias open to produce meals for the community, just to name a few. Before we get started, I'm going to remind you of a few interactive Zoom features that you can use to join our conversation. We encourage you to use the chat feature throughout this discussion to share your thoughts with your fellow participants. We will have time for audience questions at the end of our meeting. Use the Q&A feature if you would like to ask one of our panelists a question. You can also use the raise your hand feature if you would like to ask a question to the speakers. If you use this option, we can unmute your audio capabilities so you can speak your question to the panel. We have a panel of speakers with diverse healthcare backgrounds engaged for this discussion. Thank you for joining us this morning and enjoy the content. I'm going to turn it over to my fellow co-chair, Brian Walsh, who will now introduce our speakers.
Good morning, everyone, and thanks, Craig, for introducing me. My name is Brian Walsh. I'm the Vice President of Finance, or Vice President of Managed Care for Northwestern Medicine, and I'm pleased to introduce our esteemed panel today. I'll start with my colleague, Dr. Dan Derman. Dr. Derman is a practicing internal medicine physician with over 30 years of experience. He served multiple executive roles at Northwestern Medicine, most recently as Senior Vice President and Chief Innovation Executive. Dr. Derman also serves as an advisor to many medical companies and currently sits on the board of Sterilis Medical, a medical waste technology company. Our second speaker is Pratap Kedkar. He's the managing principal in Z's Philadelphia office and leads the firm's global pharmaceutical and data science practices. He has advised many biopharmaceutical and healthcare companies in a wide range of business issues and regularly contributes to publications, including the Wall Street Journal, Bloomberg, Business Week, Business Insider, and Fortune, among others. Dr. David Mona is our third speaker. He spent his career providing clinical leadership to teams achieving national recognized results in high-risk patients in a variety of settings. His health system experience includes 20 years of emergency medicine, clinical practice, and multiple executive roles. Since 2013, Dr. Mona has served as the lead physician advisor to United Health Group Ventures and the Optum Triple Aim Fund. Our fourth and final speaker is Dr. Funme Olapati. She is the Walter L. Palmer Distinguished Service Professor of Medicine and Human Genetics, Dean of Global Health, and Director of the Center for Innovation in Global Health at the University of Chicago. Professor Olapati develops focus on women, innovative strategies for comprehensive cancer risk assessment and prevention with the focus on women of African ancestry across the diaspora. She currently serves on the board of directors of Susan G. Komen, Cancer IQ, Lyric Opera of Chicago, and the MacArthur Foundation. And finally, our moderator for today's discussion is Arun Batea. Arun currently serves as Senior Director of Partner Engagement for Matter, a health and life science technology incubator here in Chicago. He leads strategic programming design and development and support industry partners in their innovation efforts. In this capacity, Arun has developed a deep passion for the focused design and strategic growth of new life science and healthcare ventures. A sincere thank you to all our speakers for taking time to be with us today. Without further ado, I'll turn it over to Arun, who will begin our discussion.
Wonderful. Thank you, Brian. Thank you, Craig, and to the Executives Club team and Megan for putting together this distinguished panel, but also for giving me an excuse to actually wear a jacket for the first time in a couple of months. So thank you for that. Good morning, everyone. Thanks for carving out a bit of your virtual schedule this morning to join us. As Brian said, my name is Arun Batea, Senior Program Director at Matter. We're a health tech hub here in Chicago. A key part of our mission is to bring industry players across the healthcare value chain together with entrepreneurs to really collectively help shape both the present and future of healthcare, which is why I'm delighted and excited to be part of this conversation today. So the future of healthcare, that's obviously a very big topic and one that we're going to just touch on here today. But it's also a topic that's taken on significantly new meaning, especially in light of the events of the last couple of months. It's been interesting, I think, in conversations and strategy sessions that we have with industry partners and with entrepreneurs. We sometimes hear about the future of healthcare as this far-off event. One that we kind of hypothesize about, build business plans for, but it's something that's far off. And what's interesting is that this future of healthcare really has been thrust upon us, I think, over the last couple of months. This pandemic has really forced us to find new technologies, adopt new solutions. It's forced our healthcare workers to work in new contexts, new processes. And in discussions we've had with our pharma partners, our payer partners, our health system partners, it has really significantly pressure tested their business models. So our goal over the next 40 to 45 minutes here is to really look at some of these big shifts that I think have rocked our system recently and project forward a bit and think about and understand from our panelists what they see the future of healthcare looking like, and what of these changes that we've seen recently might stick over the long term and might sustain over the long term. So I look forward to having this rich discussion with all of you, and as folks said, please tee up your questions in the Q&A as we go throughout the conversation, and we'll have a few minutes at the end to hopefully address a few of those. So with that, we wanted to start on actually a positive note this morning. There's been obviously a lot of news about the pandemic that can be rather depressing, but we wanted to start on a positive note. I think in times of crisis, we've heard that sometimes people want to feel like soldiers, not victims, and we've heard a lot of great stories about folks in our community, in our healthcare system, I think over the last couple of months. So I'd like to start by asking each of the panelists very briefly, take 30, 45 seconds, share a quick snippet or story, large or small example of a positive story that you've seen from our healthcare system recently. Dr. Olopade, maybe I'll start with you.
Oh, thank you for the kind introduction and for putting this panel together. I think the best story I've heard really has been the response to community testing by our hospital. And I want to thank United Healthcare for doing it. You know, every time I came to work, I found out that we had testing, but no patients to come in to test by our hospital. And then it occurred to me to ask the hospital, why don't we go into the community and begin to test in the community, partner with our community health centers, and whether by doing that, we'll be able to actually get more people in our Southside neighborhoods who have access to testing. And that really began an innovative, amazing partnership between our hospital, community health centers, and faith organizations, because really patients are in the community and we shouldn't be waiting for them to come to the hospital before we do interventions. And that's really, really transformed the way our healthcare system was able to manage, you know, getting testing in the community. We had capacity, they needed tests, and then making them, the marriage really helped us to do a public health intervention. That was really wonderful to see.
Wonderful. Dan.
Sure, thank you. Good morning, everyone, as well. 3 quick things. First, as an innovation guy, I would tell you, you know, as our mayor and others would say, never waste a good crisis. And I think we had the opportunity with this to take away all the fibrous tissue that got in the way with innovation. All that melted away in probably 72 hours, and our ability to advance some of the things that we wanted to do, whether it's in telemedicine, remote patient monitoring and such, has been able to be really accelerated. Number 2, after spending $250 to $300 million on one single instance of our electronic medical record among our 10 hospitals, I can tell you that through this pandemic and the emergency crisis, it absolutely paid for itself in our ability to create analytics across our 10 hospital system to really understand surge management capacity and whether it's testing, PPE, or any other area. And then finally, on a personal note, I have a close family, friends that are my patients. Their son recently this week got discharged from Northwestern. He was the longest inpatient for COVID. He's been in the longest intubated patient in Northwestern through the whole crisis. And he just got discharged to the Rehab Institute on yesterday morning.
Wonderful, Dan. Great to hear that, and continued success and progress for him. Pratap.
Sure. Thank you so much for putting this together. So I think just two big positive things that I'm hearing, and I'll take maybe more of a national view. You know, the healthcare value chain stakeholders, like you mentioned, Arun, are not very good at collaborating. It's always a little bit of lack of trust and slightly adversarial positions. And I hear quotes from health system executives like, normally I'm not interested in partnership with manufacturers. Right now I'm 6 out of 7. Please, let's work together. Let's get creative. Let's partner. So this idea of a common enemy uniting all of the healthcare stakeholders together and doing unprecedented things in terms of sharing, that's really heartening to see, because it's something we've been trying to get everybody to do for 20 years and it doesn't happen. And the second piece is just sheer speed. I mean, a vaccine typically takes 16 years. You know, HIV still doesn't have a vaccine after 40 years of trying. And now we are saying the world record was 4 years. We're going to do in 18 months. And given today morning's news from Moderna, maybe it's 8 months. I mean, absolutely unprecedented. So I think the fact that the world can do these things is very heartening. I just hope some of this magic sauce is left after the pandemic is over.
Great. And Dave.
Thank you. Good morning. Musculoskeletal care is very expensive, the fastest growing, highest cost corridor in the United States. United Health Group funded a company called Orthology, which focuses on non-surgical approaches to pain and musculoskeletal care. Focus on manual treatment, so hands-on treatment. We have very large operations in New York and Long Island, New York City, and Minneapolis, St. Paul. And interestingly, we transitioned to an entirely virtual manual therapy model, which you would think would be impossible. Our clinicians have done 3,600 visits. We're able to drop ship devices to patients to use in their home and be guided via video to subvert the need for an in-person visit. What we've shown over the course of the last several years with this approach is we're reducing the incidence of unnecessary surgery, imaging, total cost of care. Patients are delighted. And we can treat all sorts of conditions through video that our clinicians have been absolutely surprised can be done. And we have done, like I said, 3,600 video visits, very high patient satisfaction. So the opportunity to work directly with employers to get people to the right kind of clinician first for musculoskeletal pain delivers huge value. COVID has accelerated application of this technology.
Terrific. All of those great stories, very inspiring. For me personally, it's sort of seeing the innovations that are happening in the front lines, which has been fantastic. So let's dive into a couple of aspects of the healthcare of the future and get your perspectives. So to kick us off, I'm going to start with maybe Dan and David to share their perspectives of telehealth and telemedicine. So this is one of those areas that started off as having some traction well before the pandemic, and we've obviously seen an enormous adoption and uptake of this technology as we've tried to encourage folks to do more virtual visits. Dan, if I can start with you, curious if you've seen any signals that point to this approach being sustained over the long term, and specifically maybe indications of how this might be challenging the health system model if I'm no longer bound, geographically to a doctor's office and I can go anywhere at any time. What does that mean for health systems? Maybe share your thoughts on that. Oh, Dan, you're on mute.
Sorry, I want to make sure there's no background noise. Thank you. Couple things. Number one is what we've always known, and studies have showed that upwards towards 60% of all doctor visits, maybe even higher in primary care, by strict definition, can be handled virtually or don't need to be handled in the office. So that has been clearly delineated now and brought to the forefront in that regard. And it's interesting now that we're starting to arc towards recovery and reactivation mode. You know, we've obviously come off our peak, and now we're trying to figure out what that new level would be and everybody's comfortable with. So we'll see how it really shakes out in the end. But it was clearly evident to both our doctors, our providers, and our patients is in many instances, it's a much more comfortable way of conducting and doing business in terms of a visit. We'll leave out a second for the personal touch and what role that plays. Some of the most simple barriers are still around that set of biometrics that are required to make a visit the best utility. There's a lot of really cool emerging technology that's out there. There's an Israeli company called TytoCare that gives a package of goods that include all kinds of biometrics. I tell you that ear examination is better than the one that I do, or the throat exam is clearer than the one that I do in an office, as an example. So I think those barriers, there's ways around it, although there's a matter of getting the equipment and the cost and all that. But so I think it's going to be here to say our doctors have been very excited to adopt it. It's interesting. There's almost a contest among them about what percentage of their visits are remote based. I think the challenges also provide opportunity. And I would say the opportunities and challenges are a couple. Number one is we've all built our physical plants for healthcare systems based on a world of inpatient visits. It is a fact that if 20 to 30%, let's say it shakes out at 20% even, theoretically, we will need 20% less volume in terms of facilities to treat the same number of people. Maybe we'd expand our base and we could grow without added capital. That could be one advantage. Maybe we could redeploy different areas to different clinical usage. And then finally, for a system like us that has a distributed network of 10 hospitals, we finally, and I think this is really the biggest short-term game, I think we're finally able to make most efficient use of people working at the top of their license. So all of a sudden, you know, a myeloma expert in our hospital can now distribute his or her care across our 10 hospitals in a much more efficient and better way than they can today. So I think that's going to be one of the short-term advantages, whether it's in cancer care or ICU care. We look forward to that. And we've taken advantage of some of those from day one with ICU care and COVID management.
That's great. So some real opportunities for scale with some infrastructure implications. David, from the standpoint of maybe a payer that was, you know, reimbursing these visits before, obviously with the explosion in the adoption, do you think that will continue to trend? How might payers be thinking about this space?
It's a great question. Payers have been a rate limiting step in providing support for this, and part of it's because they aren't convinced they're going to get the same result as they get in person, and they're concerned about overuse and quality control. So we've done a really rigorous job of measuring the impact we're having and documenting high satisfaction among patients. The ability to distribute into geographies such as rural geographies with specialty services like home-based palliative care, for instance, and that we're getting very similar outcomes, including reducing emergency and unnecessary hospital visits using video technology and home monitoring. So this period of time has given us an opportunity to really build an evidence base demonstrating that the fidelity of these technologies produces a very similar result in the right settings to what can happen in person. It's more efficient, it can be distributed in geographies that were impossible to reach with in-person care. And for the payers, it's a tremendous advantage to be able to offer this kind of access for their members. So I think that, at least at United Healthcare, what I've seen is that the eyes have been open to the effectiveness of this. And in a company like Prospero Health, which is our community-based palliative care company, we're now covering rural geographies and drop shipping technology to people that don't have access to Wi-Fi, that don't have smartphones, still are very high risk with serious illness. They can turn these devices on. It's connected to cellular networks. They hit a button, the device is configured. We start video visits. Yeah. What's important is for payers to actually see things that work, that are tangible, that translate to value. And this has been enough time for us to demonstrate that in a number of instances. So I hope that that creates the momentum to continue the payment models post-COVID.
Oh, great point. And as Pratap mentioned at the outset, this has given rise to some interesting new opportunities to collaborate, and maybe a great opportunity for health systems and payers to come together and look at the last couple of months and see some of the value perhaps that's come out of these telehealth and telemedicine visits to see what can sustain long term. So great insights there. Another large sort of aspect of healthcare that's been in the spotlight recently has been this area of diagnostics and testing. So we've seen an evolution in diagnostics from, tools that simply detect and diagnose disease to really smarter technologies leveraging a variety of data, genomic data, proteomic data, that's now helping us be more predictive about disease and helping us optimize sort of the course of therapy. Despite this evolution, though, we've seen some challenges recently to screening, tracking disease trajectory. So maybe a question for Dr. Olopade and for Pratap. I'd love to get your thoughts on whether you see from a diagnostic standpoint this evolution will continue, or do diagnostics need to play a fundamentally different role in the future, or how will the diagnostic model look like going forward?
Yeah.
Dr. Olopade, maybe if I can start with you.
Yeah, some of the innovation that's really come to the space where I'm in is in cancer diagnostics. And just like Dave said, we have a continuum of care that comes from preventive, and now we're talking about preventive oncology, preventive cardiology, and testing. And I'm hoping that post-pandemic, we're going to really embrace what we call population risk stratification. If you don't know your risk for COVID, you may really underappreciate how deadly this virus is. The same thing. What's your risk for cardiovascular disease? What's your risk for cancer? And so for telemedicine, we've been able to really get cancer genetics and genetic testing distributed into the community of practice. So there are doctors all over this country that are actually trying to adopt guideline-based, risk assessment, but they just don't have access to the testing. So in this era where we can actually deliver genetic testing over the phone, over a virtual visit, we can match testing to the patient wherever they are. And it's always been my vision that, in fact, we'll be taking drones to deliver cancer medicines to patients in their home. And that's really what's exciting about this moment, that we can unite. I've had calls during this pandemic. I've had meetings with scientists all over the world that are really excited about the innovation that's coming from vaccine discovery that may come to help cancer patients, or from telemedicine that will help us distribute how we connect knowledge to action at the community level. So I think this is really exciting. So whether it's sending tests home, and home kits now are being tested in a way patients are able to access genetic testing without leaving their homes. We're looking at other ways to transport our tests across state lines. So I think it's really going to get us to be more efficient. And then super specialists like me can basically stay in my office and consult with anybody anywhere in the world. It makes our job a lot easier. And I think this is the moment that we've actually been waiting for, where we can do risk prediction, and then we can be better in stratifying patients. So our high-risk patients get care where they live from the experts that can help them understand what their risks are. And then if we do risk stratification, you don't have the risk, then maybe you can go to work. Maybe you just need to wash your hands. But this is not the moment for one size fits all. And I'm really excited that we can now begin to adopt population risk stratification from prevention to end-of-life care in cancer.
That's great. Pratap, from your perspective in working with pharma and medtech clients, how are they thinking about sort of the role of diagnostics going forward in that model?
Yeah, no, I think it's absolutely poised for a revolution. I think over the next 5-6 years, long term. One of the things that pharma thinks about is precision medicine, right? So can this particular drug, which costs hundreds of millions of dollars to develop, who should it go to? Because of course, if you give it to everybody, it doesn't really have a very good hit rate, and lots of niche drugs now, so you can't really follow that strategy. Now, to echo some of the remarks that were made, 74% of all cancer trials actually are with a biomarker now. So the whole role of diagnostics is not to say, do you have the disease? It's, is this the right patient for this treatment? Which is a change in the question. And because now, and that philosophy is getting into the actual trials itself, right? Because it's hard to come up with this approach after the product is out there. Then it's more a matter of collecting real world experience. But now that it's part of the trial, I think we will unleash a new wave of products that go with the test together. It's a very different way of treating disease, because you need to do population health. You need to figure out, broadly speaking, we all know 5% of patients correspond to 50% of the cost. So if you want to get the cost curve down, you have to do this proactive population health screening too. So diagnostics is being used in these two new ways, which is I need to go with the product, almost like a pair, and I need to go with the population, with the patient, to figure out how to treat, as opposed to something that is merely one tool in the broad range of tools that a doctor uses today. So I think that shift will make things more efficient, more effective, not just on the product side, but also in terms of bending the cost curve.
And as you all see that evolution for diagnostics, how would you respond to folks that might say, but the last 2 months have been getting basic diagnostic, getting basic tracking, screening technologies into the hands of healthcare providers who need that. Have we evolved sort of past some of the basic needs that we have in times like this? Yeah,
I mean, it's a paradox that we in the US do very good with the $1,000 or $10,000 test, but not the $1 one.
Yeah, but yeah, I mean, the real issue is, you remember that it's all about resources and resource allocation. And what's really exciting about this moment, we've talked about the disparities, the fact that there are inequities, the fact that Black and brown patients are dying from COVID, partly because there's even been unequal distribution of testing. You can now imagine a healthcare system where it doesn't matter where you live, we can deliver a test to you, and we can pair that test with an expert that can interpret the test and make recommendations about what you need. I really think this is the moment where when we start talking about precision medicine, it's about really the roadblock that's really prevented precision medicine from getting to where it needs to be, is that there hasn't been the resources invested both by healthcare providers, health systems, to make sure that you have interventions that can scale. And in the terms of scaling, technology can allow us to scale. You can do risk assessment. You can, we talk about there are not enough genetic counselors in this country. Well, you can do genetic testing if you take the test and you pair it with a expert that can interpret the test for you. And you don't have to be physically coming to the University of Chicago or to Northwestern. So that's why I think some of the laws that allowed us to practice across state lines, that allowed us to be able to provide expertise, those are going to be transformational going forward.
Sure. Great points. And so it's, you know, for us to think about, when we think about diagnostics and testing, it's not necessarily the actual technology as maybe the rate limiting step, but it's the business model around that, how we increase access, how we deliver those tests to people that need it. So great opportunity there for us. You know, one of the key pillars, obviously, to the future of healthcare is the degree and sophistication of technologies that are developed. And just to make this a little easier for our arms to get around the topic, you know, technologies can maybe fall into one of four buckets. One is improving healthcare access, which we've kind of talked about. Delivery of care and delivery of health as a second. Third might be technology that enhances health versus simply treating sickness. And the fourth is the consumption of health, how we consume it, how we engage with it, and what our experience is. So maybe Pratap, if I could start with you, this is open to all of us. Curious, as you look at maybe those four categories, where do you see some of the greatest innovations or growth coming from as we think about the future of healthcare? What sort of which of those categories do you see as being really important to building a strong and vibrant healthcare ecosystem?
So I'll actually piggyback off one of the questions that just came in from one of the participants, which is a technology I'm closer to, which is artificial intelligence. And the question was, how do you see the role of AI playing out in the future? I'm a big believer in that. I got my training there. So I sit at the intersection of AI and healthcare. And so to answer your question, Arun, I think the impact of AI is in many places in healthcare, but in healthcare delivery, I think is very key. One of the things that we've been studying at ZS is what are the patient and doctor attitudes to AI, right? Nobody really wants AI in the exam room. And we discovered something very interesting. I think with a lot of physicians, you know, there was some skepticism, but the role of can AI be a sort of advisory assistant to you? Someone who can help you actually look at all that test data, all the data coming in, all the EMR stuff, help me become more productive, and give me digest some recommendations, some things I may have missed. I'm of course the final arbiter, but AI as a way to help the doctor become a lot more productive, efficient, effective is really appreciated. I think about 50% of the doctors already in a survey we did said, yeah, I could do that. I'm willing to work in this partnership. Of course, they have to make sure that things are, you know, trustworthy and explainable and all that. And the other really surprising thing was from the patient. The older patients were actually very positive of the view of AI coming into the exam room and helping, because you know what they said? They said, well, if AI is doing all the grunt work with the data and the computing, maybe the doctor will actually look at me when I'm talking to them and not be on their EMR. So the idea that AI will free up the physician to connect again with that doctor-patient relationship, the human empathy, the bond, that aspect of it, which will be lost a little bit through telemedicine perhaps, but I think that's very important to the patient. And so the question is, in the future of medicine and delivery especially, we need expertise, but we also need the doctor-patient trust, the relationship, the bond. How do we get AI to help with one so the second can be reestablished while it has been sort of getting chipped away over the years thanks to EMR and other things? So I think that's a very interesting way for us to look at improving both the patient experience, but also the role of the doctor and help them practice at the top of their license, like Dr. Derman said.
Terrific. Dave, your perspectives on that?
I would say access is really the part of the equation that's been key parts of infrastructure have come together in terms of smartphones, cellular networks, internet access. Amazon's demonstrated that the shopping experience can be created in your own home, and with FedEx and UPS and all the delivery services, the whole supply chain and the ability to acquire a product has changed. And I think in healthcare, we're going to benefit from all that infrastructure that companies like Amazon have benefited from and be able to provide access to services that were really limited to certain geographies. So I would say the distribution of healthcare is going to be much easier to do. and has been demonstrated in this time where we have been really allowed an opportunity to accelerate adoption of these technologies. So from my perspective, it's about access and personal experience that are impacted by technologies that are available in the home and now being leveraged by healthcare in a new way.
Terrific. And Dan, from your perspective as our requisite innovation guy, curious to see or understand what you've seen from a technology perspective that excites you.
Sure. I'm going to take a very tactical approach here as opposed to big picture strategy. This phone here is, if you think about healthcare and the adoption of apps in all of our life and health, excuse me, in healthcare, probably the most predominant app for our patients would be access to their healthcare system through their medical record and their EMR. That just scratches the surface, in my opinion, about the utility and use of apps and technology from your phone in our everyday life. I think there's a tremendous opportunity to conduct conduct a fair amount of our interactions, all the way from community activities to the most sophisticated participation in clinical drug trials. There's a real opportunity to marriage this idea. When we talk about consumerism in medicine, I think where the rubber hits the road and where the place it declares itself is right on everybody's personal phone. And our ability to drive towards that and adopt that, I think, is an incredible opportunity over the next 5-year horizon.
Terrific. And Dr. Batea, just to close the loop on the question, and I know you've been involved in a startup company, I might ask this question a little bit differently also, is technologies that you've seen that excite you, but also how well prepared are we as startup communities, as an innovation community, to address some of these new challenges? Curious on your thoughts there as well.
I mean, a lot of experiments are going on now with wearable devices. For me, I am an oncologist. I treat cancer patients. And the reason I started Cancer IQ was because I was frustrated that, we spend a lot of money at the, end of life, where in fact, preventive and social medicine can get us a lot if we can actually integrate preventive and social medicine into practices. And so now one of the things that I'm excited about is a whole new area of preventive oncology. That in fact, what we know is that all the risk factors for cancer, all the risk factors, the comorbidities that we're all talking about now for COVID are also comorbidities for colorectal cancer, for breast cancer, for lung cancer. And if we are able to, based on human behavior, based on monitoring our patients with wearable devices, based on being able to communicate risk a little bit better, then I think we can motivate patients to actually do something to reduce the risk of cancer. So for women, a lot of people are really looking for physicians to be able to communicate risk clearly for them. So as I walk around during this pandemic, I see people taking walks. I see people thinking about reducing stress. I see people thinking about how they eat nutritious foods. And I'm thinking, wow, we're going to reduce cancer at the end of the day, because these are things that are really important for us to be able to adopt. But I think if we wait in hospitals and we only have this discussion with our patients after they come into the hospital, we've lost the opportunity for prevention. So this is why I really love those contact tracers. If we can convert all those contact tracers into tracers who are going to monitor comorbidities for patients at home, who are going to help them exercise better, who are going to push communications to them that actually make sense, I think we're going to make that big leap in the area of prevention, whether it's cardiovascular disease, diabetes, and it will help us reduce costs in the long run.
Terrific. I'm going to ask one last question before we switch to Q&A. And my apologies, my internet went out for a second, so my ask to the exec team, it cleared my cache of questions on the Q&A. So if you guys wouldn't mind helping to tee that up, I'd appreciate that. Last question for the panel, kind of a lightning round question, keep it really, really short. As we look back over the last 2 months, curious about what learnings you all have taken away from the current crisis that you believe are critical to building sort of this bright future of healthcare. And those learnings can be inside of healthcare or outside of healthcare. But what do you think has been really pertinent for you as you think about that future? Dave, can I start with you?
Yeah, I would say the digital application of healthcare services works, and it's very highly scalable. And it's going to solve a number of issues that seemed insoluble when we had an in-person model only. And the other learning is that we really have learned to value the combination of in-person and digital. People want an experience that is unified, so to speak, or continuous. So pulling together services so that from a person's perspective, they're aligned and working together as opposed to one-offs in various apps and various locations. Digital gives us a great way to knit together in person and the digital experience.
Terrific. Pratap.
Sure. So I think, again, looking back 2 months and saying, where do we go for the next 2 years? One concern I have, not concern, but the phenomenon I think we're expecting is rules turned into fear, and fear is going to turn into habit, right? So I think when patients demand convenience, they demand telehealth, they demand remote diagnostics, it will become more of that patient actually wanting this. I'm already hearing things like, I hope I never see you again, doctor, in person, right? The idea that I don't have to come in and do this 2-hour routine. So I think finally patient convenience and patient empowerment will get its rightful place in healthcare. It's been lagging for a long time. So to me, that's a positive that's coming out of this. The slight negative is structural, which is, people are talking about half of primary care practices going under as a result of this. But we need that linchpin. We need primary care to play that role structurally in healthcare. And so that's one of the negative things I see. I hope it doesn't happen, but along with the positives will come some of these negative ramifications which we have to watch for.
Sure. Dan.
If I could take a snapshot of the level of teamwork and cooperation across the entire healthcare landscape, and then show that to everybody a year from now, and if we were operating at about 50 to 75% of that level a year from now, I would be ecstatic. So I guess I would say that the level of teamwork and our ability to get stuff done within our own institution and across institutions is absolutely stunning. And I hope we can figure out how to capture that and realize that together we're stronger and we can get stuff done. And it's more working together as opposed to against each other.
Terrific.
Yeah, if I may add to this level of collaboration and cooperation that we've been having. The global health arena has always been sort of put into the infectious disease bucket in most healthcare system. But that, as soon as we started having to deal with our ICUs being overwhelmed by COVID, our colleagues were talking to their colleagues in China, talking to their colleagues in Italy who had gone through this. So our hospital system actually was learning from our colleagues who had gone through the same problem. And I think that collaboration, that global effort against this pandemic is also going to be really coming into all areas of healthcare where knowledge is going to be shared. And I think innovation will be shared because physicians and scientists and patients, advocates all over the world are going to come together to push us to do better and to have better outcomes. So I'm really excited that that global collaboration is happening.
Terrific. Let's address some questions here. So maybe for Dan or Dr. Olopade, there's a question around physician and healthcare worker wellness. What have we learned about? There's obviously been a lot of issues of burnout from physician and staff. Any learnings from healthcare worker wellness that will translate to fundamental change in the future?
Well, let me start by saying that we've kind of taken, everyone's dividing this new world into different buckets. Interesting enough, and I don't know whether it's the right one, but we have the 3 R's, response, recovery, and our third one, as opposed to new normal, we're calling it resilience, which really talks about how we can all, how we're all going to survive and retool ourselves. And in that bucket, we've actually been spending a fair amount of time thinking about this nourishment of our own healthcare. And I'd say that we're taking baby steps. We're far from being experts at it. But, one of the things that we've done is taken our mental health side, our psychiatry department, and really put them together with our head of our medical group to be proactively thinking about what that health looks like, and with the head of the hospital. So I can't say that we're particularly adept at it yet, but at least we've taken the step to marry them together to start to look at those things.
Yeah, and in terms of sort of what I've really found during this period is this intergenerational support that we're giving each other. So, our young physicians are the ones who are the front line, and they retired the old physicians to stay in their rooms because they're in the high risk category. But we come together, we have seminars. Our seminars are better attended now more than ever before. And you have a sense of community that's coming together again. We have appreciation for nurses. By the way, the WHO is celebrating nurses this year. And a lot of people in healthcare are women. And all of a sudden, you see these women who are leading our healthcare, these women who are at the bedside, these women who are making it possible for patients to survive. And I think that interprofessional and interdisciplinary collaboration, I hope, will get us through this. And then beyond this will get us to really see that we're in it together. And so I've really found that when we feel like we're a community, it's not us versus the administration or the executives, that we feel encouraged. All of the clapping that's being done, there's not a better time to be in healthcare than now, or to be a scientist trying to find a cure. So I think that's helped our morale, and I hope it goes forward after this.
Hope that continues for sure. A question for Dave and Pratap. I'll pose this to you. There are a couple questions. I'm going to combine them around the use of AI in medicine. How do we sort of prevent AI from becoming a crutch, if you will, that we lean on, that tell us what to do, as opposed to, Pratap, as you mentioned, sort of a supplementary or a complementary tool? A couple of people are wondering what might prevent that from happening, and how do we remove some of that the liability as a result of using AI? What do you guys see in that regard?
I can go first. So that is definitely a tricky one. I think there's a couple of enablers that have to happen. The first is that the AI has to be transparent. It has to be a glass box, not a black box, because the moment it turns into more of a black box, people will just abandon their accountability, right? It's like, well, the machine told me to do it, and you never want that answer. We definitely see some of that happening in other industries if it's not managed well. And some areas you don't have to manage it because it's well capable of doing the job, but here there's a very different dynamic at stake. So I think that's one. Explainability, transparency will be key. I think you'll also need very, very strong validation. It's almost like airplane systems, which is part of the question. What the FTC, what the government does in terms of 10⁻⁹ capability testing of a plane and its systems, that's the same discipline we'll have to bring to healthcare as well. So I think if you put a couple of those in place, we can be sure that the AI can be trusted, but we also have to worry about the physician and not delegating and getting rusty, so to speak. I think that's part of the question as well. But to me, it's more like, you know, what happens with education. The medical assistant, the fellow, they do part of the role today so that the physician can do less, not have everything from scratch. So can we come up with a different way to work where these roles and AI are playing their role in the supply chain, so everybody is practicing at the top of their license? It's something we will have to invent. It's something that doesn't come naturally, but I think we have enough traditions in healthcare to build upon.
Dave, any thoughts on that? Oh, you're on mute, Dave.
Sorry.
There you go.
You can hear me. So I think the key is keeping clinicians highly engaged in how these technologies are used, and patients. How is it impacting their experience? Is it helping or hurting? I would say in the EHR world, we didn't do that very well. And the EHR implementations have really impacted the clinical experience. And at the end, we can all say they're a great thing, but the path to get there was extremely painful. And I do think AI and other technologies that can facilitate some work that is very repeatable, and an AI solution can be very reliable, are going to be important in the future. I think the key is keeping the users, patients, clinicians highly involved in understanding how they're used, implementing, evaluating the effectiveness, and really keeping an eye on the healthcare experience for the users.
Terrific. Let's maybe take one last question, and I'll open this up to the group, but maybe Dr. Batea, I might start with you. I'm going to broaden this question a bit. There's a question around at-home diagnostics. We were talking about diagnostic tests sort of expanding into communities that maybe don't have access to it today, which requires a certain level of health literacy. And it speaks maybe broadly to the question of accessibility of healthcare services and healthcare products. How do we help ensure that healthcare literacy remains high, that as we think about a future of healthcare where diagnostics are delivered via drone to different communities that don't have access to it today, that they can take use of it very effectively and efficiently? Can you speak a little bit to your thoughts on sort of how do we improve the healthcare literacy side of things?
Yeah, well, you know, so the television has helped us tremendously, because now everybody understands what coronavirus means and why a vaccine is needed to save us. And I think what's really been lacking is our ability to communicate clearly without using jargon to our patients, knowing that if we are able to really bridge that gap, we are going to be able to connect with our patient. I think there's need for innovation in how we communicate, both as scientists and as physicians. I've been really impressed by the way we're using comic books now and using digital media, using so many different ways, even demonstrating how to wash your hands by singing happy birthday. Why couldn't we say that in terms of how to reduce your diabetes risk by, so I think that we now need to begin to place what we want to tell patients in the cultural context of where that patient is. And I think we've learned a lot during this pandemic about those who have been left behind, either because they're in rural communities or because they don't speak English or they don't understand what the whole majority population actually have been talking about, because we need to go and meet them where they are. So that's why I'm excited about community health workers. I think all those contact tracers are now going to become leaders in their own communities to disseminate good information. So I think that's going to help us in the future. And I hope we take this really seriously as we move forward in healthcare.
Wonderful.
I think,
go ahead,
to
Dave.
tag on to the community worker comment. We found finding people in the community that are from the same culture, same community, can be really effective ways to translate, so to speak, some of what needs to be translated into the correct cultural context and way of communication. This has really come to life in end-of-life care. and different cultures have different points of view about the healthcare system and access to the system, and that influences use of services at the end of life. And we've found it's so critical to have a person within the culture accepted in the community as an understanding advocate of what it is we're trying to accomplish on behalf of the patient. And it's a great translation.
Terrific.
With
that, go ahead.
Yeah, let me just go back to the in-home diagnostics and combining with technology. I think that the Star Trek or Dick Tracy world where our phone becomes a diagnostic tool is no longer a thing of the future. I've seen some technology where you actually can attach a 3-step home COVID test result to your phone so that you do the person will do step 1, 2, and 3, connect the device to the phone, and the result will be downloaded to the healthcare provider. That's here today. In fact, in Africa, they've been using that in HIV already for years, and that technology is here already today.
Terrific. With that, I'm going to, great conversation on sort of the future of healthcare, both on the technology side, but not only healthcare, but human care and what we need to do to move that forward. So thank you all very much for those insights. Greatly appreciate everybody's time. Nitin, I'll turn it over to you to wrap us up.
Great, thanks Arun. Good morning, everyone. I'm Nitin Jain, a principal at ZS and one of the fellow co-chairs for the Executive Club Healthcare Forum. First of all, please join me in thanking this wonderful panel virtually. Thank you for a great, insightful discussion. There were a lot of great takeaways. The two that I took away personally, the first one is this acceleration of future trends. I know for many, many years we've been talking about telehealth or value-based partnership, even the impact of EHRs, but as our group was talking about, those trends are accelerating. So that was one takeaway that I took. And the second one was impact of teamwork and partnerships that cuts across organizations, cuts across countries. It's a new muscle for many of the stakeholders, and I hope that trend continues past COVID. With that, I hope you found this information useful. Please keep an eye out on future events from the Executive Club, and I wish you a good rest of the week. Thank you.
Thank you.